Hey, GP learners, welcome to this episode. It's slightly unique. I'm going to do a watchathon of the NHS England webinar about general practice access. It was just waiting for it to start. Andy's not joining me today. Oh, look, I'm knocking my microphone and everything. And just waiting for it to kick off because we're going to hear about, obviously, the new letter that's come through, the impact that's going to have on general practice and what this possibly means for what we do and how we do things. So if you've ever joined any of the webinars before, they're produced by NHS England. You have to sign up to them. There's sometimes a capacity issue with these, which is why I thought it'd be good to kind of do a watchathon effect. I may show bits at points. So I'm not going to show the whole thing just because I'm aware I'm not even sure if I can do this, but I've checked. There's nothing that says that you can't live stream them at the time. So it'll be a good test for this particular one to see whether or not this is appropriate or sensible to do so. Don't know if anybody's going to join and watch with this as we do it and things, but I think it'd be a useful thing to do. And if you like this, let me know. More than happy to do this again for future things. In particular, I guess there's the NHS England webinars. There's other kind of ones that they do as well, whether that'd be useful for you out there in general practice to see, do, etc. So we're still waiting for the event to start. It's now 1 minute past 5. But hey ho, that doesn't necessarily mean anything in terms of how it works. And what are we doing later on today? Well, actually, myself and Andy are going to be live streaming again at 8 o'clock, and we're talking about a variety of things at that point. Following that, we will then be doing on Saturday, we will be doing a live stream about the actual letter itself and our perspective. So that'll be really interesting to join us for, because obviously it is an interesting letter and how this means and works and stuff and things. So we will see how we go from there. But I don't know. What do you think? What are you seeing, hoping? It'd be interesting to know what you think and stuff, and we'll take it from there. Unfortunately, we're still waiting for the letter to start. Sorry, the webinar to start and things. And I have no idea whether they're going to start on time. May or may not do. I don't know. Yeah, I think we're just sat here waiting. If anybody wants to say anything whilst we're here, if you are watching live and stuff, feel free to do so. But we're just going to sit here and wait, I think, because I can't keep talking. Can I? I don't know. What do you think? Let's just take a pause and look, I'll show you my screen so you can see that I'm not being crazy about this. So if you are joining us for this live stream, we're still waiting for the webinar to start, the live event from NHS England. Hasn't done so yet. I know it's meant to start at 5 o'clock. I don't know why it's not started. We will find out. Maybe it's going to be delayed. Maybe it's, I don't know. Be interesting to find out. But yeah, hope you're finding this useful and eventually effective when it's, oh, looks like we're starting and things. So this is a live watchathon. So I'm going to talk through it as we kind of see what's going on and stuff and things. Hearing people talking about getting rid of stuff. We can see the opening slide with the agenda start time, 5 p.m. Wow, 1,200 people online during the webinar, and opened by Amanda Doyle. Okay. Okay. So questions into the chat. Okay. So this is the agenda that you can see on the screen. Amanda Doyle speaking at the moment and hearing about how this is going to look and work. Okay. Talking about the money separately. Good to hear. Oh, lost the audio. Can't actually hear what Amanda's saying. Okay, let's come back in. So recognition of a stepping stone contract. Sounds like they've only been given 1 year's worth of money. Okay. That's a shame. You know, general practice time and time again has overperformed over every other part of the healthcare system, and yet it's the one that's struggling the most in that sense. From so interesting key point there. So no targets this year. Be interesting to see if that maintains itself. Okay. That sounds good for me as a PCNCD. I'm interested to see how that works for the members of the networks and stuff in terms of what that means for them. Definitely true. I think different people have different perspectives on that. I think it works really well in some places. Okay. So that's useful to know, and I would recommend that you do complete the incentive schemes forms that are out there. We've got videos on that on the GP Learning and links I'll try and put later on. So that's a 2% increase. Yeah. 2%. Okay. Okay. However, no attempt to change that mistake. So interesting to hear that point. Key point, they're committed to review it. They haven't committed to pay what the DDRB say. And obviously, we do know that the DDRB does respond to the government directly as well. So it is not necessarily independent. So my understanding of that is that you get more of the initial payments for QOF on the assumption that you then have it. I guess there's a downside if you don't make those 80%, then there may be a clawback as a result that will impact some areas different than others. So that's approximately a 20 to 25% increase in the capacity and access payments. So depending on your network size, you'll get some more funds. Okay. Ah, so let me see if I can fix the sound. Apologies. I've just been told that you guys can't hear what I'm hearing, which is not how it should have been. You should be able to hear this. Let me see if I can fix it. This is why this one's not fully broadcasted for that reason. So I'm going to try resharing. Let's have a look. See. Okay, let's just switch this over. Hopefully that'll mean you guys can hear as well as I can hear. Let's see if it does work the way it should do. Maybe not. Okay, so I can't fix the sound on the fly. So apologies, everyone. I can't fix the sound on the fly. Just have to join in. I'll try and explain it as we go along. But let's bring it back so you can see at least. Did it there? So looking at those 8 key metrics, you can see there: call volumes, calls abandoned, time taken to answer calls, missed volume calls, wait time before the call was abandoned, callback requested, callbacks made, and average call length time. And looking at those metrics and looking to improve them. So it'd be interesting to see how that works moving forward. So you have to review the data. I'm assuming this will replace. So we're going to hear that QoF QI is going. This will probably take place of QoF QI, I would imagine, as part of that roll up of the funding. And then the hope is this will better understand demand. This is one of the reasons why the better purchasing frameworks were brought in with the monitoring metrics that they have. Okay, so we're going to talk about PCNs now. Okay. So enhanced access is staying the way it should be. Well, it is, sorry, not should be. And that's not going to change. But the other specs are going to be rolled into one. So that's your cardiovascular, that's your anticipatory care, that's your care home les work, I believe. So that'd be interesting because that will be wrapped into this as well and how that will look. Be useful to see how that works and things for people. Okay. Interesting. Moving away from the prescriptive elements of controlling the PCNs. Okay. So the PCN clinical director role is going to change to simply be around coordinating the service delivery and the resources that you've heard about, supporting the practices directly and making sure that modern general practice works, as well as integrating with integrated neighborhood teams. Not much on that at this point, but it'll be interesting to see how that goes. And they're going to roll the various different funds, so PCN clinical director pay, leadership and management payment, into one fund, and then you can allocate that as you see fit for your network. So I think different networks will do that differently. Hopefully no restrictions in that by the sounds of it, in terms of how it will work. So you can use those funds based on your specific needs. That was always the design or the hope for the design of PCN. So that's a positive step in my view. Okay, so we're moving on to talk about ours now. So the additional roles reimbursement scheme. couple of changes here if you haven't already seen this part. So the comments about increasing the flexibility, if you've watched any of the channel before, you'll know that I always feel that they are too reactive in this basis, but obviously there is some real positive stuff here. There's this new role of enhanced nursing roles. So if you don't know what this means, so you've got your practice nurses, you've got your advanced nurse practitioners above that. The enhanced nurses is basically in the middle of the two. So this is probably designing how your practice nurses are when they have a specific focus, whether it's hypertension, diabetes, etc. They would be your enhanced nurses, but not at the level of an A&P or an ACP level. So yeah, can't be a generic practice nurse according to them. The clear words from Amanda Doyle in terms of the genericness not being part of it. Okay. Again, bringing back that additionality clause that many of us are mindful of, but sometimes gets forgotten in the PCN world and stuff. So the reason why I'm laughing, the keywords here, you can employ any direct patient role that you need except GPs. Do you need your ICB to confirm that? But there we go. Yet again, unfortunately, GPs are not part of the R's roles. Obviously, additional element being there. Obviously, that's one of the key requests by the BMA and the GPC and stuff. So that's definitely not on the cards there. Mm. So interestingly, removing the caps on the roles. The mental health practitioners, I think, will be an interesting one for that. And adding some more about training and apprenticeships to the roles. I think that's more focused on the personalized care roles when I've looked at the details and stuff. Okay. So Amanda's specifically responding to the request to add GPs to the R's roles. And yes, she just said what I said. It's not an additional role. Okay. And clear direction there that they don't want R's to compensate for a shortage of clinicians elsewhere. Well, bit hard to deal with that one, isn't it? Okay, so we're talking about incentives now. So first on to QOF. So 32 will be streamlined out of the total 76 QOF indicators. So 42% of them are going to go, and these indicators will become income protected, of which 19 of those are the register indicators that were previously protected this year. So So just to go through these, because I know it's a bit smaller on your screens and stuff. So mental health, all six parts of the physical health checks will people with SMIs completed will be income protected. Depression, people with newly diagnosed depression who are reviewed soon after diagnosis will be income protected Depot 4. Asthma, percentage of patients with asthma over their smoking status or exposure to secondhand smoke recorded, asthma 008. The register indicators there that you can see for the 19 different conditions, the QI indicators will be protected. So therefore that continues 74 points. That's one of the bigger ones, including the registers. Percentage of relevant patients from COPD who've been referred to pulmonary rehab programs. That's got an interesting one because it's whether you've got access to those and they let you refer. I know in our local area that doesn't work as well as it could do. Smoking, percentage of patients who are smoking, that will be protected 25 points. percentage of patients with cancer who have a care plan within 12 months diagnosis is protected, as well as cancer newly diagnosed patients with a review within 3 months. We're now going to talk about IAF, although the slide hasn't changed. There we go. It has now changed and stuff. So they are stopping three of the indicators for IAF. So that's the vaccinations ones in particular, remaining leaving basically the cancer screening one, which is the fit testing indicator, and learning disabilities review indicator. They will stay. The remainder will be basically cut, and then the funds from that rolled into the capacity investment fund, which is why it's now gone up by 42 million, I think it was, if I remember rightly. So the reason for keeping the fit test one, according to Amanda Doyle, is that because the wait times for lower GI cancers has the only area that's reduced. So they obviously feel that this has had an impact and then had a positive benefit for patients and the system as a result. So therefore, that's quite good. Hmm. Okay. So here's the minutiae changes. We're going to get to an interesting one, I think, but we'll see if they cover it. So registering with a GP, the online mechanism is going to be rolled out more and made more effective. We've got recognizing the importance of continuity care. The GP contract will be amended, explicitly require continuity care to be considered and determine appropriate response when a patient comes to the practice. No details on this. This is a potentially a big one. Okay. Important recognition that they don't want to add just some box ticking into this. Change to workforce to collection. So this is going to change to a quarterly basis on the National Workforce Reporting Service. So more live reporting compared to, I think currently it's annual, if I remember rightly. Weight management enhanced service is going to continue. Right, so receive £11.50 per referral from a total funding of 7.2 for the enhanced service itself. If you have the resources to do so, I think is the key thing here. So the comments, it's not tied to a measure or money. It'd be interesting to see whether that continues into next year or the year after. Also, if patients choose to wait for a particular clinician outside of the 2 weeks, that should be exception reported. And then the commentary about the vaccine sharing information that's been asked by the vaccine teams. Interesting, because I guess it raises a question about data sharing and stuff. I'm not 100% on top of that. However, Amanda has missed out another change. So sections 14, 15, 16, and 17 in the annex about the changes to the performers list changes. So now we're going to get the questions asked. We'll have a flavor. I suspect we won't get any specific ones. So I'm not going to show the questions because obviously I don't have permission to show the individual names of the clinicians and stuff. So I could do that, but I'm not going to and things. In fact, let's just take it off the screen for now and keep me so I can have a quick look and things. So there's a comment that it reflects the general feeling and stuff. There are loads of, oh my gosh, I'm still scrolling. I'm on infinite scroll and it's still going. Oh my God. Wowza. Okay, let's go to I don't think I get to the top. Well, let me go to the top. This is crazy. Okay, so I got to the top. The number one question with 87 votes behind it is contract letter references 2% per growth pay and has a discussion been had with the government as minimum wage. Many of our staff, lower pay than this, has increased by 9%. This affects the whole general practice pay structure. So what's the plans? So interesting recognition with Amanda Doyle about the fact that people are not happy with this. Um, key comment there is that this is the envelope they've been given by Department of Health, and they are not able to go over that. Um, Missed that bit. Something about discretionary payment made by the BMA, but key things that there's no changes. Okay. Comments by Amanda Doyle that the envelope cannot be increased. She has no ability to do so. Again, comments the DDRB review will be looked at, not abided, looked at. I think that's a key point to be aware of. Mm. Mm. And recognition by Amanda Doyle that the government has the choice not to take the recommendations as well. Okay, so interesting point, and I kind of agree with this as well. So Amanda commenting about the fact that you know, let me make sure I get this phrase right. So there has been an additional investment in general practice, according to Amanda Doyle. The percentages, I think we could argue, in terms of total NHS budget, is a different factor. However, that she admits that that investment has been to do additional things, and actually, one of the key things is looking at the amount of workload that's then being doing, which is why the demand information needs to be assessed and understood to make that more understandable and manageable and things. So, fair comment there, to be honest. Okay, so the minimum wage question being asked now. This is a key one. Be interesting to hear. So comments that this was raised, even with the uplift not being enough to compensate for minimum wage increases. So comment that they have no information about the rates of pay that any staff are paid. So the comment that agenda for change does mean that they can calculate how much people are paid. Okay, fair comment. Mhm. But the comments that they don't have that details, I would argue that that's been could easily be provided. It has been provided in some ways through the general practice finance surveys and stuff, because practices would have provided top level figures. I guess individual pay clearly can't. Bandings maybe would be more appropriate. So they're looking at estimates as well. Okay, interesting concept. And the comment that no part of the NHS has been accounted for that. Okay, and again that's the position, the financial envelope that they have. It's not okay. It's a balanced response. I will be honest on there. I think important to recognise it's a key challenge for many practices, and that will have a impact on how many staff we have available for practice teams to support with and things. And we're having some technical difficulties with the webinar. Unfortunately, the person asking the questions, Alex, seems to have frozen and disappeared, and they're just trying to get somebody else to support them from there. We've got Gabby coming on now instead. So we're talking about digital telephony now. Is there going to be any targets associated with data? So no targets, according to Amanda Doyle, associated with the digital telephony. Comments about every practice being available from the 1st of April. Disagree with that. Most practices won't be available, but a lot will. So maybe 50-50, I would estimate, but it should be by the end of the financial year following. And I agree with that. A key comment about how the fact that the data you get from these systems could be quite useful to plan and speculate your demand, needs, and uses of staff and things. So no targets attached with digital telephony. Again, repeated comment on that. I hope that stays true. I really do. Now a question about the asks for the capacity and access improvement plans, payments, sorry. So this is around the 30% extra payment. Again, comments 70% is going to be paid up front, which has been the case this year. So here's the key thing. To get the remaining 30%, all your practices have digital telephony in place. That should hopefully be happening for most practice networks. Have a simple process for accepting online requests. And have to implemented some sort of navigation and triage. Now that's the key part, I think, that may fall down in some places. There is support. Importantly, there is support around this, and it'll be a thing be interesting to look at and things. Signposting to some of the NHS England how-to guides by Minal Bakai, friend of the channel and stuff. So feel free to have a look at those. And the PCNCD has to certify that the practices have done that. Relatively easy to do, to be honest. I think it may be an issue potentially for some practices who are very resistant to digital triage and stuff, but I don't think it necessarily means it has to be total triage. That's the key. They haven't said those particular words. So unfortunately, one thing that hasn't come through listening to this so far is one of the other changes that I know I'm trying to mention this earlier, 14, 15, 16, and 17 in the annexes about the changes to the performers list. That hasn't been commented. I wonder why. Unfortunately, I've asked the question, but it's not going to come up. I don't think it's much lower down because obviously it's nowhere near the importantness to some people on the finance and things. Let's try again, shall we? Okay, so I've asked it again. Comment about how if more stuff moves to digital, then we may see less on telephone, and that would have a negative impact in the figures. But then, so a question about is social prescribing still in the DARES? I believe it is, but and is there going to be protections around how the money is spent in terms of the pooling of the PCN funds for leadership and PCN clinical directors, etc.? So I appreciate for many of you, you can't hear what I'm hearing, which is interesting. And I'm sorry, I'm been able to figure out the audio for this live stream. It was a last minute ditch. I wasn't even sure I'd be able to make it back in time to make this, but it is an interesting webinar, and I would encourage you to attend and join the future ones. I mean, they mentioned they've got 1,000+ people joining it. So it seems they have fixed a lot of the capacity issues they had previously with these webinars, particularly during COVID and stuff. But yeah, interesting to hear. So comments, there's no restriction on how you spend the funding. So if you are watching this live with me, I would really love it if you stick some comments to see what you think about this. I'll happily bring them on as we go across and stuff, but it'd be interesting to know what you think. So if there's a few of you, 6 people joining me live watching this as well, but let me know what you think. I would love to hear what you're thinking. And also whether you think this is useful. Actually, should I do this again in the future for future webinars and stuff? Or obviously, if I can fix the audio side of it, that would be great if I could do that. But maybe I need to think about a different platform to do it and stuff and things. So key comments, there's no restrictions on how you spend the PCN CD funds, leadership funds, and the capacity and access improvement funds. Q, that's a good question. No comments about premises. Okay, honesty, no solution for premises. That's good to hear in some ways, I guess. So some updates to the cost directions are coming apparently by Department of Health, but no date on those. So focus on simplification rather than fixing. But recognition there's a big ask there for premises and the fact that capital investment for funding and etc. Is challenged. So recognition that the workforce has gone, nope, but the premises has not. That'll be looked at as a separate issue. Okay. Oh, thinking on this question by the looks of it. So questions about workforce balance with managing modern general practice, triaging absolutely everything and stuff. And that looks like that's going to be the last question as well. And so they're not going to ask my question about the workforce changes in terms of performers list. So there is again the availability of the transformation funding for practices to move towards modern general practice, 13,500 on average. It depends on your list size. Key focus about repurposing your workforce rather than increasing your workforce to solve the issues of demand. Mm. Okay, some honest recognition about the fact that people are angry about some of these changes and stuff. That's useful to hear from Amanda. So some really emotional responses in here. One, so after your letter, I've handed in my resignation. So you forced the loss of another JRP partner. Oh, okay. So recognition of over 500 questions. I'm not. Yeah, that's probably right. So some commitment to and analyze the questions, pick out themes, and respond to those directly to the people attending the webinar. I can share those if I get them as well. Happy to do so. However, I'm aware that this will be available to people when we talk about this on Saturday at 2 p.m. An interesting recognition they've done this at speed. That is true. Obviously, the letter came out last night. They've got a webinar done today. Useful, I think. It really would be great to have some proper discussion. Open invitation to Amanda Doyle and the team if they wanted to come and discuss it with me and Andy for a controlled environment and stuff. So I'm trying to shift my share closer so I can talk better. Again, that open invitation to the team from NHS England to come and join EGP Learning for ever any discussion on the contracting stuff and things. They're finishing the webinar now. Apologies from Amanda that there's not answer to every question and stuff. Fair point. I think actually it's been a really interesting webinar. Cogent, interesting points. A bit annoyed that they have missed out a couple of areas, like I said, from the letter, and the webinar is now over. So hopefully you found that really interesting, pertinent stuff. I can see a comment from a colleague of mine, Mark James. Yeah, thanks a lot. Appreciate you taking the time to do this. Look forward to the discussion on Saturday. Yep, definitely looking forward to it. Just to point out to people, it is going to be slightly later than planned, we think. So originally me and Andy were going to do it at 11 o'clock. Unfortunately, Andy slightly caught up with something, so we may have to do it at 2 o'clock. I know that's different, but absolutely you can join us for the rewatch and stuff and things later. Thank you, everybody. Hope you had a great evening. Catch us tonight as we talk about some other very pertinent things and probably discuss the letter in brief, but the bigger discussion of that will happen on Saturday. But we've got some really interesting stuff for you tonight, talking about the acute access model, particularly from the Foundry PCN, and what is obviously developing into the Northwest London model in terms of mandated contracts and stuff. I hope you're all great and catch you all soon.